Ladies and gentlemen, please welcome Bob Cusack, Editor-in-Chief of The Hill.
Thank you. Hello. Thanks for coming this morning. My name is Bob Cusack, Editor-in-Chief of The Hill, and I'm delighted to welcome you all here today to our event, Unlocking Access to Oral Health, where we will discuss the progress made and what more could be done to improve oral health care nationwide. I'd like to thank our sponsor, CareQuest Institute for Oral Health, for their support of today's event. Today, with the help of members of Congress, medical professionals, and oral health advocates, we will be exploring what the federal government can do to support states and ensure access to quality oral health care. But before we get into this important discussion, I'd like to address a few housekeeping notes. In addition to our audience here in the room, we are also live streaming this event on thehill.com. Please keep your phones on silent for the duration of the program. However, we do encourage you to join the conversation, as always, on social media. You can follow us on Facebook, Twitter, Instagram, at The Hill Events, and we'll be using the hashtag The Hill Oral Health. And with that, I'd like to welcome my first guest, Democratic Representative Jan Schakowsky of the 9th District of Illinois. Please welcome the Congresswoman. Thank you so much.
Okay, good.
Well, you know how this works. I usually ask you questions, but talking backstage, we're going to flip the script, and you've got a question for the audience.
Okay, so please, if you would raise your hand, how many of you have really terrific dental insurance?
Okay, about
two people, and then I'm
it might have been a little more than two.
Yeah, I thought that's way more than I thought we were going to have, and that means to me cleaning and screening, and root canals, and crowns, which are scary words for a lot of people. We don't have a lot of good coverage for dental care in this country.
And that leads into the question, where are we as a nation? You know, when I used to cover healthcare for a trade press newsletter back then, really before the internet got going, and I would pitch oral health stories, and I wouldn't get a lot of excitement from my editor. I would still do them. But where are we, and why is this issue underrated?
Well, it's underrated unless you have a big toothache. And 74 million people in 2019 had absolutely no dental health insurance, no coverage at all. And it's a serious healthcare problem. It can actually lead to more diabetes, increase in diabetes, and multiple cancers. I mean, dental health is a really important issue, and I would say while it's way under addressed, it can't be underrated. And we also know that I have some statistics that 29% of low-income people say one of the reasons it's hard to get a job is if they don't have the presence of their teeth in a good way. So it affects all aspects of life, and seniors are greatly affected because, as you know, Medicare does not cover. Well, it doesn't cover dental, it doesn't cover eyes, doesn't cover hearing, and these are really, really devastating problems for older Americans who, again, if you don't have good dental care, it can affect all aspects of your life. So this is, there in other countries like in Great Britain, it's part of their healthcare coverage.
Right.
In the United States, it just really isn't.
And what should, when Build Back Better was moving its way through Congress, there was a lot of talk of expanding a lot of services, including dental.
Yep.
What does Congress need to get done Obviously, maybe not in this Congress, but in a future Congress.
Well, I've been part of a letter that went to CMS that says that, can CMS move ahead and try and do something on this? I don't know.
Like administratively, instead of without legislation.
Administratively, they seem to agree on that. They're beginning to look at that. But I think that, certainly you would hear from most Americans that, and especially seniors, Medicare. And Medicaid, by the way, it's an optional coverage, except for emergency care, and 36 states only cover for emergency, and that includes also DC. So it's really not very available. So if we could do something administratively, that would be good. There's enormous support for doing it as a Medicare benefit as well.
As far as the pandemic, how do you think that has set dental health back? Because a lot of people just haven't gone to the dentist.
Well, I don't know about you, but my dentist was not operating for most of the pandemic, as you can imagine, that kind of close contact. I will admit before all of you that since the pandemic, I haven't been back. I brush like crazy and I floss every night. Just saying. But
you should get checked out.
Absolutely, right. I know that. I will. Okay, Bob, I promise. I will. So clearly there was this big drop off in all kinds of healthcare screenings, and but I'm sure dental care for many of you. I don't know if any of you were able to go to the dentist during the pandemic.
As far health, you've been a healthcare leader for many years. Healthcare, as you know, can be partisan, but it can also be bipartisan. 21st Century Cures Act, oral health, you would think would be bipartisan. Is it?
It's bipartisan if you ask people. When it comes to legislation, harder to do. And the expansion, as you know, in the Build Back Better legislation, we actually did add those benefits. But there is no Build Back Better. And so it didn't happen. We're fighting for more care. And I think that it certainly shouldn't be a partisan issue when it comes to healthcare. The other thing I think to note is that when it comes to FQHCs, the public health, the community health centers, very few are able to offer dental care. I'm lucky in my town of Evanston, Illinois, the Erie Health Center. They actually have dental care there. Not very, very common. So low income people, dental care is really hard to afford. Can I give you a few dollar figures?
Absolutely.
They're just pretty shocking on how much health care can cost. We know that the cost even of a screening can be like $50. But then when you get onto a root canal, it can be $800 to $1,800. A crown, $1,000 to $3,500. I mean, these, and a lot of that is not covered by insurance, and so it's not done.
Right.
And
you touched upon it. So in Illinois, different states have different rules. Illinois is better than most as far as dental care. You get that sense?
Not great.
Not great, but okay.
Again, Medicare. So Medicare Advantage. Some of the Medicare Advantage programs offer some dental care, but in Illinois, the networks are so confined. It has to be an in-network doctor, and because they're so limited in states like Illinois, so it's not very good.
We're going to talk about it on a panel conversation, but then there is the question of cost, and just like COVID, the more you invest in preventive health, it'll pay you back, and obviously many in oral health make that argument. As far as Medicare and Medicaid, which you've been working on for a long time, what needs to be done for the sustainability of both, especially Medicare, which is going to need some type of fix because it is headed for bankruptcy?
It's just really incredible to me that we think we should eliminate or reduce the kind of federal funding for these programs. So what is the consequence of that? It means that people don't get the health care they need. The United States is unique in the world in that saying that we think of health care as a right of all people. Of course, I'm in favor of a Medicare for all program. And as you point out, at the end of the day, I think that we see the kinds of savings in health care. If you don't provide these basic preventive services, then people are going to end up sick. They're going to end up in the hospital, and they will become a public charge of some sort, or they're just going to die. Is that the standard for the United States of America? We can do much, much better.
Healthcare, obviously, a big issue, and poll-wise, it's a big issue for Democrats because they poll better than Republicans. As far as the Inflation Reduction Act, which had some healthcare prescription drug legislation in it, do you think that was a signature win heading into the elections fewer than 50 days from now?
Oh, there's absolutely no question about it. When it comes to healthcare, again, particularly for older Americans, when you cap the cost of prescription drugs at $2,000 a year, which sounds like a lot of money, but I run into seniors whose bills are $2,000 a month for their life-saving drugs. That says that insulin will be $35 a month out of pocket maximum. These are absolutely really great things, and we begin to negotiate with the pharmaceutical companies that Medicare can start negotiating for lower drug prices. Let me just say that this is a huge issue for Americans, and we pay, as Americans, 2 to 3 times more for the exact same drug available in other countries. I mean, we're a bunch of chums when it comes to big pharma, and so this, and it says actually that if the pharmaceutical cost is higher than inflation, that pharma companies will be asked to rebate. So we're making some progress here, but we as Americans can do better. But I think we're here talking about dental care. I think it is one of the absolute biggest failures that most Americans, just a few people here in this room, and these are people who one might assume can afford the dental care that they need. But you live in fear of a crown. No, please.
Yeah, that's
I can't.
Scary stuff. Yeah,
Yeah.
As far as policy making, obviously it comes down to elections, and the midterms are coming up. A few months ago.
Really?
Yeah,
I heard that.
I didn't know about that. It's going to be a big thing.
Less than 50 days. I think it's 49 days.
Yeah, we did a big story on 50
counting?
days to go. What's the mood in the House Democratic Caucus? Obviously, a few months ago, it was looking grim for both the House and the Senate. Things have changed, though. Do you think you can retain the House, and then next year, if you did, and the Senate, you'd be able to build upon what you've already passed this Congress?
We're going to win.
You're going to win.
Oh, we, Democrats. We're going to win. We're going to win. The enthusiasm, I've been an organizer for most of my life. I can never really remember a time when there is so much energy out there on the Democratic side. And I have to say, any poll that was taken before the Dobbs abortion decision, forget it, throw it out the window, because we are seeing a tsunami of women. But it's not just that. I think the fact that we actually can count up delivering for the American people. As you mentioned,
Yep.
the Inflation Reduction Act, which does so many things in terms of the climate and in terms of healthcare. So I am feeling very, very positive. I've also been on the recruitment committee for the Democrat Congressional Campaign Committee. I believe we have superstars out there. And I have to say that when even Mitch McConnell has some disparaging remarks about some of the
His own
winners,
candidates.
Republican winners of the primaries, I feel especially energized and excited. Yes.
That would be a historic win if you were to defy the odds, historically based upon what is normal. Of course, we're not living in normal times.
Is anything normal right now
No.
out in politics
Yes,
right now?
yeah.
I mean, I just haven't seen it, and of course, there's a downside, I think, for us to lose, but I think the upside, as you mentioned, being able to address these questions of healthcare, to address the concerns of Americans right now, voting rights, human rights. I think the sky's the limit in being able to pass so many important things that protect our democracy.
Last question, you've worked with Nancy Pelosi for a long time. If you defy the odds and keep the House, well, you think she comes back as Speaker?
She was asked that once recently.
Yeah.
And she most properly said, she's focusing 100% of her time, as I am, on the upcoming
winning.
election,
Yep.
and that will, of course, determine
Everything.
what she's going to do. I think even set the stage for what happens in the presidential election in 2 years later. So we don't know. This is. I think really to be decided in so many ways in less than 50 days.
Yes, politics
Vote,
is
vote, vote.
unpredictable. We're out of time, Congresswoman. Thanks so much for joining us. Please thank the Congresswoman.
It's been a
for joining us.
pleasure. Thank you. Thank you. Thank you.
Thank you.
Okay. Thanks, Bob. Okay.
Oh, yeah.
And now it's time for the sponsor perspective portion of our program, brought to you by the CareQuest Institute for Oral Health. Please welcome to the stage Mary Backley, Chief Executive Officer of the Maryland Dental Action Coalition, and Mehek Kaura, the Chief Policy and Advocacy Officer of the Kentucky Youth Advocates and the Kentucky Oral Health Coalition. They'll be joined in conversation by Dr. Kaz Rafia, Chief Health Equity Officer at CareQuest Institute for Oral Health.
Good morning. Good morning, everyone. It's so great to be with all of you here in person, and thanks to everyone joining us online virtually. My name is Kaz Raffi. I'm the first Chief Health Equity Officer for CareQuest Institute. It's a true privilege. CareQuest Institute is a leading national nonprofit focused on creating a more accessible, equitable, and integrated oral health system for all. We do that by collaborating with payers, providers, thought leaders, local, state, and federal stakeholders to be able to accelerate the transformation of this oral health system to make sure it is in fact equitable and actually makes sense. We know that oral health is inextricably connected to our overall health. That's been established. Yet oral health care and its access is non-existent and it's inconsistent where it is available. And that happens across all socioeconomic status, but particularly the impact is for those that are low-income Medicaid recipients. And it's this lack of insurance, it's this lack of coverage that downstream is a driver for health disparities. This health disparity is particularly felt across the underserved and marginalized communities. And what we're aiming to do is to really strengthen this dental benefit, and that is going to be a critical piece in advancing oral health equity and equity overall. To advance this conversation, it is an absolute privilege to be joined this morning by Mary Backley and Mehek Kaura. Mary is, of course, the CEO of Maryland Dental Action Coalition. Is this thing still on? Did it go off? Mehek is the Chief Policy and Advocacy Officer for Kentucky Youth Advocates and Kentucky Oral Health Thank you for joining me. Oh, thank you. Wow, just got super loud. Thank you. Both Mary and Mehek have been instrumental in increasing access to dental coverage. In Maryland, Mary and her team have helped advocate for a bill that creates Medicaid adult dental benefits. And in Kentucky, Mehek works each year, and I want to talk about that, to prevent cuts to their existing Medicaid benefits for Kentuckians. We'll spend the next few minutes discussing these and learning about the work on the ground and what it takes to actually not just get to where you all got, but the everyday fight that needs to happen to make sure those cuts are prevented and how it translates into advancing our overall picture for health equity. What I want to do, Mary, is I want to start with you. Tell me what it took legislatively for you and your team to go out there and actually do the work that needs to get done to make sure this Medicaid adult dental benefit is passed for Marylanders.
Well, thank you. It's lovely to be here. It really took developing a relationship and a rapport and a stable of oral health champions in the Maryland legislature to educate their colleagues in Annapolis on the importance of oral health and the inequities and disparities that existed in accessing oral health care, particularly for Maryland adults who really hadn't had coverage in over 30 years. And this really led to the legislature instructing MDAC to do a study. They wanted to know about the financial implications. So a study on the financial implications of adults going to the emergency department for chronic dental conditions. And we fortunately were partnered with DentaQuest Institute in doing this study. And it was really a groundbreaking study. It was a revelation in terms of showing the amount of money that Medicaid was devoting to paying for emergency department visits that were not treating the issue, just the symptom. Medicaid was paying for 53% of those visits, even though the Medicaid participants only account for about 15% of the population. So it was really quite revealing. And what I thought was really incredibly critical to this point is that DentaQuest Institute not only did the aggregate for the legislators, but they also broke it down by county. So we were able to give those reports to our members, to our partners, to our stakeholders, for them to talk to their individual legislatures and show the impact of what was happening at the community level with their constituents. This led to the establishment of the Adult Dental Pilot Program, which provided care for thousands of Maryland adults, Medicare, Medicaid adults, which really, again, was another layer of showing the importance of oral care to overall health care. And then, it was really kept moving forward. We worked to incrementally incorporate oral health into state health systems and worked to ensure the success of the pilot program, but at the same time, continued to work with our legislators and the governor, which, for instance, resulted in the expansion of postpartum coverage. The governor put money for postpartum coverage for 60 days, and then we worked with the governor and the legislators immediately the next session to expand it to 12 months. So we were expanding the adult population that was receiving care. And CareQuest Institute followed up the emergency department study in 2020, produced a similar report with similar results. It showed that Medicaid continued to pay for the vast majority of costs associated for emergency department use, even though Medicaid participants represented a small part of the adult population. This led to, at the MDAC summit, the legislators announcing their intention to file legislation, which passed.
Wonderful. That's amazing. I love the connection between the economic value and
Yes.
how it translated and was validated. Mac, I'd love to hear from you about your work in Kentucky.
Yeah, certainly. So in Kentucky, a third of our population is actually on Medicaid. So we look at it from a budget perspective, that's close to half of our budget in Kentucky. And so the last I believe 3 years now, it's been where we've been really advocating to sustain that Medicaid budget and bottom line and protect that budget. And I say that because COVID has kind of illustrated the need for Medicaid and showed how people really need that care. And so that's what we've been doing. We've been mobilizing our advocates. We've been utilizing data similarly to what Mary has been doing in her state.
That's wonderful to hear. I mean, I'm so grateful for the work that not just are you doing, the wins that you're taking, but the continued fight to make sure that there's not a creep, if you will, in the coverage that exists. Now, while Maryland and Kentucky are really lucky to have you and your collaborators and your colleagues who are out there doing the work, this is, we know, not the case with all states. There are quite a few states out there, as the Congresswoman talked about, that either do not have Medicaid adult dental benefits, or those that do are inadequate, as we know. Earlier this month, I'm proud to say that CareQuest Institute launched a tool along with some of our colleagues out there to be able to sort of assess where dental benefit lies, where the overall dental benefit lies nationally. And we're really hoping this tool becomes something for policymakers, advocates, and administrators to identify opportunities to move forward with advancing the work that you all are doing on a national scale. This next question really speaks to health equity, if you will. I'd love to hear from you individually as far as the impact on someone who does not have access. What does it look and feel like? What are the individuals out there feeling that don't have this access? Mac, I'll have you start.
That's great. So I would just like to say that.
Yes, of course.
Oh, thank you. I would just say the mouth is the gateway to your body, and so we know that it impacts the systems that we see every day. The Congresswoman has kind of illustrated the effects of oral health and its impact to health in general. But as a child advocate, I think something that's important that we need to share is that when parents have coverage, then children are more likely to have coverage, which means that they're also more likely to go to a doctor and a dentist and utilize that coverage. And so that's something that we're seeing as a child advocate.
Thank you for the question. Dental care transforms lives. It all ages, and if you have poor oral health, you're suffering. If you have poor oral health, you are dealing with chronic diseases that are getting worse without proper oral care. You're having a hard time getting employed, seeking employment. I see this every day with the Medicaid participants in Maryland, and the best news really is when I do get these phone calls from adults looking for care. When I say January 1, coverage will start, you could just hear the relief in their voices, and it's transforming lives. It changes a life from suffering into actually living.
And what you just talked about is validated through CareQuest Institute's State of Oral Health Equity Survey that was just released. And these are numbers that are not new to anyone who's in the business, who's in the know, who's aware of what downrange feels like for the individuals who don't have the coverage. We know that 60% of Black population reports tooth loss associated with periodontal disease or caries, and this is compared to 45% of population outside of the Black individuals surveyed, and higher population of Black and Hispanic population self-report oral health that is fair to poor. Those are certainly opportunities for work that needs to be done, and difficulty access to care has also been reported in this particular population. What I'd love to know about a little more, though, is how, when you did the work in the legislature, if cost was in fact a part of the argument that was made. I know you hinted at it. I'd love for you to expand on the cost impact, because it's really, really critical in making a cogent and salient argument.
Absolutely, cost is always an issue. Whenever you start an issue, start a bill, start a legislation, everybody says, "What's the fiscal note?" And frankly, we looked at cost not being a cost. It was an investment. It was an investment in the health outcomes of the Maryland adult population, and it was an investment in the fiscal health of the Medicaid. CareQuest Institute, DentaQuest Institute documented that Medicaid was providing funds for coverage that was not addressing the issue, not addressing. And then you also have the correlation between good oral health and chronic disease management. Subsequent studies showed that Medicaid participants, in particular New York State, who suffered 2 to 3 different chronic diseases, when they had dental coverage, the costs associated with management of those chronic diseases, such as cardiovascular care, decreased. So it's not a cost, it's an investment. It's an investment in the population, it's an investment in the systems, and it's an investment in health outcomes.
Thank you. Mehek, briefly, if you can identify if you think there's opportunities for the federal government to sort of have more push in this area.
Certainly, I think there is. If you've just noticed with the American Rescue Plan, one thing that was provided with the American Rescue Plan is the option for states to utilize and extend their postpartum coverage for women. And that is really exciting news. And I know once that opportunity was there for states, we've seen states such as Kentucky going ahead and implementing that. And so if more states were given that opportunity, I'm sure we would expand oral health coverage.
Thank you both. I know we're running out of time. I just want to be respectful of other folks being here. I just want to, first of all, thank you both for being here. I think the community and advocates' perspective is really important if we're going to work towards an integrated oral health, expanding access, and improving outcomes. Thank you all. I appreciate the opportunity.
Thank you.
Shirley, let's start with you. You opened your private dental practice, 1985, treating patients with severe physical challenges. What did that experience teach you and guide the policy-making aspect of what you do?
Well, that's an excellent question. I saw the need, and I was trained at Howard University College of Dentistry and the pediatric residency, and my heart went out, and I decided that I would focus on patients with severe mental and physical challenges. That was a population that seemed to have been forgotten about. And so my practice grew from seeing 6 patients to over 3,000. But what I saw initially was that all of these patients are wards of the District of Columbia, and they're on Medicaid. And the fees for Medicaid hadn't changed in over 20 years. And so the DC government decided at that point that treating patients with disabilities, they would increase the percentage of reimbursement, but it was only in that population. Mm-hmm. But what about the other population? Of course, children were allowed to have dental coverage, Medicaid coverage since the 60s, but after the age of 20, then it stopped. And so it's important that everybody's covered across the board. And now most of our patients mine are senior citizens, and they don't have coverage. Very limited. It's either emergency care or you just see them.
And how does that affect their lives?
Oh, well, of course, there's studies out there that show that adults have lost more than one tooth. And of course, if we connect that with nutrition and being able to eat, and then with a toothache, you don't brush. And so then there's periodontal disease involved. And we all know or have been made aware of at this time how the oral cavity affects overall health.
Fred, we're going to go to you. Families USA has an Oral Health for All campaign. Can you tell us a little bit about that?
You bet. A goal that all Americans believe in, we all are fighting for. Health should be something that is there to ensure we can all live our fullest life, not a reward for a certain job or a certain kind of insurance. And we've been dedicated to oral health care for many, many years. And fundamentally, what we know is, as you've heard today, mm-hmm. There are so many ways that oral health care really impacts the ability of somebody to live a healthy life, the health of their entire body, their mental health, their chronic illnesses. But it also has influences on, here we go. Sure, no problem. It also has influences on their ability to work, their ability to be social. We know that right now in this country, if you're a person of color, you're much more likely to not been able to secure employment because of the condition of your mouth, your gums, your teeth.
Right.
We know that you're much more likely to feel shame about the way that your mouth looks, the condition of your gums and teeth. And so at Families, we are very dedicated to the idea that in order to achieve health for this nation, we've got to address fundamentally the connection between the mouth and the rest of the body. And I have to say, I started working on these issues decades ago, and in particular in the United States Senate about 15 years ago.
Mm-hmm.
And before that, I had worked with primary care associations, with public hospitals, and we've come so far. And I think we should be really proud that understanding awareness of the American public of oral health care has come so far. The percentage of folks that actually have access to health insurance, dental insurance, has gone up significantly. And the conversation with policymakers, as we heard this morning, have really changed. Initially, I worked for a senator from New Mexico, one of the poorest states in the country, a majority minority state, and we would travel the state, and we would go to health policy commissions all over the state. And the number one issue that the doctors who were working on the commissions brought to us was oral health care. That was the number one issue for the people of New Mexico. They said, we've got to address what's happening in their mouths because we can see the impact on the rest of their bodies. And back then, it was so hard to really get policymakers to focus on this issue. Oral health care was sort of seen as a luxury.
Right.
It wasn't seen as integral. And last night at dinner, we were talking about this. It was the death of a young man here right outside of DC that really galvanized, Diamante Driver, that galvanized action in DC, in Maryland, and in the United States Senate. It really changed the whole conversation. When a young man dies because of a cavity that's gone septic and then eventually into a sepsis and eventually into death, that's not a country any of us should be living in.
Marco, you're an economist, and you've written a lot about how expanding coverage will save money in this area. Can you talk a little bit about that?
Yeah, and let me just first react a bit to what Fred said. And you heard the Congresswoman say about the job search prospects,
right,
and the employability of people, what Fred's alluding to. Like this, I think, is changing the conversation, right? We are paying an economic penalty in the status quo. And if you look at the data and that issue that she mentioned about lack of coverage and poor oral health limiting your job search ability, the data are crystal clear. If you are a low-income adult and you live in a state that doesn't have adult Medicaid coverage, you're twice as likely to say that poor oral health limits your job search skills, right? So compared to if you're living in a state that does have adult coverage.
Uh-huh.
So I don't know, to Fred and to Cheryl's point as well, like I think we're at a point where maybe the momentum is building. We have much more feathers in the cap or bows on the arrow, whatever the analogy is, in terms of saying, look, it's the top unmet healthcare need. The top. Not prescription drugs, not primary care, not vision, not eye. Oral health is the top unmet need among low-income adults and seniors as well. We have an economic thing. To your specific question, we did, and we worked with Families USA and Community Catalyst. We crunched a lot of numbers. And if you look at when we did the report, there were 28 states that didn't have adult dental coverage in Medicaid. And we estimated it's about a $1.1 billion investment per year that you would need to cover dental care for adults in Medicaid in those 28 states. Now there's an offset as well of about $300 million in medical care cost savings. That's a really, really conservative one.
Right.
So I think if you're talking about, I loved what was said earlier about an investment, right? You need to think of this as generating savings elsewhere in the healthcare system, in reduced emergency costs, in reduced chronic care, medical care expenses, et cetera. So I think, I don't know, we're having more of the pieces of the puzzle, and I think we can talk about kind of what's needed to go to the next level. But in my view, there's wonky data, there's lots of personal stories. I would be disappointed if it takes a Diamante driver in some state, an adult on Medicaid, a senior that loses their life because of that. I mean, do we need that to drive policy? I mean, I think that's almost shameful. We have what we need.
A follow up on that, but I want to open it up to the other panelists. But you mentioned state coverage. You know, in Washington, there's so much gridlock. We talked about the death of Build Back Better, which had some provisions on oral health in there. We're seeing with abortion now policies really being made at the state level more and more. Is that how to change the system? Is to go state by state? Obviously, ideally, you want to have federal legislation that applies to all the states, but with the gridlock in Washington, is that where the battle needs to happen?
I don't know enough about that. I mean, I'm not in the advocacy space, but I will say that I think there are two potential federal solutions.
Okay.
Right? And I think one is to basically say, like we did for children 20 odd years ago, oral care is an essential service in Medicaid for adults. And you basically have a federal policy, right, where you must, and it should be comprehensive and adequately funded, et cetera. I mean, I don't know the gridlock, how big it is and how much of a lift it is to get that stone up the hill. The second policy option to explore is simply enhancing the subsidy from the federal government to states through the FMAP, right? Like we did this through the ACA, right? You're expanding Medicaid rolls. The federal government will pay, you know, almost all of it for a certain number of years, et cetera. This is what I'm talking about. Another option is to say, if you add adult dental, you will have a significantly enhanced match from the federal government, at least in the first X number of years. So I would say those two are the options to explore. Now, politically, what's more feasible, that's not my forte.
Your forte, though. What do you think?
Yeah, and prior to coming to Families, I was running healthcare for the National Governors Association and working with a lot of state Medicaid programs. And the first thing to say is, absolutely, incredible progress can be made and has been made on the state level. You know, we're now at a point where basically half the states have pretty robust oral health care coverage, and another half are sort of in either none or some.
But what has been? Let me stop you for a second. What has been the key there to getting that progress?
So without a question, it's raising the awareness of policymakers of that connection.
Okay.
The body and the mouth connection. Incredibly important. And I also think the norms in our society are changing around oral health care. People's experience of having access to insurance coverage that covers their needs, their oral health care needs, has helped them to be able to access care. So we're also changing in terms of our national understanding of oral health care is changing. But I was going to say, you know, we have to remember that unlike the federal government, states have to balance their budgets. So they can't just print money if they're spending too much money. And I've sat there in the room with governors and Medicaid directors when, for example, Sovaldi hit a very, very expensive drug to treat hepatitis. And the first thing on the chopping block was oral health care, adult dental oral health care, because it's seen as a kind of luxury at times, which it isn't. And if you look back at the recession in 2008, the first thing that was cut was oral health care, and in addition to some optional populations. So I think we have to understand that there's a fiscal dynamic on the states. And just to reinforce Marco's point, we have to show up in a way when we're advocating for this to understand that concern and address it and not ignore it and jump over it. Because if we don't address it, we won't win this. And ultimately, if you think about this sequentially, every single state that is currently covering oral health care in a meaningful way, if we can get a bill through Congress that says, hey, we're going to make this a mandatory benefit, but we're going to show up and help the states pay for this, cover the cost, every single one of those states that's currently doing it becomes a champion for this bill because we're filling in part of their financial spend, right? And eventually, and not everybody agrees on this, but eventually, you know, we've been fighting to make sure that there's actually the adult Medicaid benefit can get all the way to become a Medicare benefit. And if you think about that interaction, what happens is the spend on the Medicaid side becomes an offset for the Medicare side. So we're just building the case slowly but surely to create a unified, comprehensive, ubiquitous, meaningful oral health care benefit. And I would say, if you look at the trajectory of this, we're well past the halfway point on this. We are really making a lot of progress. And we, you know, I spoke directly to Speaker Pelosi on this. She was 100% on board. The HR 3, the prescription drug negotiation bill, had the Medicare dental benefit. I mean, we are making progress here.
Cheryl Lee?
Yes, so I just wanted to say that having adult Medicaid is important, but it also can't be the Band-Aid, because the state might say, we're offering adult Medicaid, but we're restricted in the treatments that we're allowed to do. So does the coverage only cover extractions and doesn't cover replacements? So I want us to be clear about that. And then you have, I think I was on a webinar, the ADA gave it, and they were talking about different states who will allow dentists to sign up for Medicaid but not treat one patient. Mark, you probably remember
Those were
that
our
one.
data. Yeah.
And so, and those are the states that I think you're referring to. I think Maine was one of them that
Yeah.
absolutely does that. So it's important. And then, of course, you know, the National Dental Association supported the dental benefit in Medicare, and so I know we're working really hard to make that a reality. But just give the adults quality insurance so that we can do what we do, and then also not restrict us, because there are a whole lot of things that we can do, even down to, you know, periodontal treatment and having them to have access as readily as they need it. And then the only option of extraction wouldn't be the only thing on the table. So I just want to make that point.
What can the administration do? We've talked a lot about Congress and pending proposals, and there's legislation by Congressman Berrigan and Senator Cardin out there as well. But for any of you, what can the administration do that you think, okay, this will help, that you don't need legislation for?
Fred, do you want to jump
Sure.
in?
Well, sure. I would say, I want to say, you know, we've worked really closely with the Centers for Medicare and Medicaid Services, with HHS on this. We have a whole new role within HHS around oral health care. The Biden administration is 100% bought in. They've got great staff who really understand the importance of this. So I think right now, they're working really hard to encourage states to expand adult dental, to work with them, check that box on your state plan amendment, start offering that benefit. I think they've been pushing behind the scenes congressionally to say, look, we can show up in a much more meaningful way. And I do think that ultimately, as we've heard from all the panelists, it's that fiscal interaction with the states that's really at the core of this. And I think that they are real champions in trying to get Congress to step up, not only create a requirement that adult dental is covered, but also to help the states cover the cost.
Fred, can CMS do an enhanced match, or that's a regulatory change, or that's a legislative change?
Generally speaking, it has to occur. It's a statutory change
It would
because
be,
the FMAP
okay.
formula is built into the statute.
And what about I really love what Cheryl raised about we're using coverage loosely, right? So far in this discussion, you hit a really, really key point. What are we talking about, right? We just heard the Congresswoman this morning poll the audience about satisfaction with coverage, and we know there's tons of problems with the current dental insurance paradigm, right? But what states have got it right? That you're not just funding extractions, but you're actually funding, Cheryl, jump in, I'm not a dentist, right? Endodontic treatment, right? You're funding perio treatment to retain teeth. You're doing the stuff that's clinically necessary versus like checklists of procedure. And shout out to CareQuest for leading the charge, and we're happy to contribute in terms of measuring this coverage in a really, really good way. Like what states do provide endodontics, prosthodontics, dentures, etc.
Right.
How would we design a benefit like we did for children, EPSDT, that says you got to provide this. This is the minimum basket. Is that, again, regulatory or is that legislative? Like you got to cover these services.
So it's both, but that is an important policy consideration in building the legislation, right? There could be a link between the quality of the coverage and the ability of states to pull down that federal match. We can actually create a connection there to say, if you're going to show up and provide a comprehensive benefit, you get full match. But if it's something less than that,
You don't get
a
full
dollar,
match.
right? So there's a lot of ways to incentivize states to get it right. And then, of course, CMS ultimately, in a regulatory sense, will define the quality of coverage that we'll get, that will qualify. Right now, because it's optional, it's pretty much an open season on, you know, a $500 benefit, $1,000 benefit, whatever states feel like doing. I will say, in terms of a good example, one of the things I'm really proud of is District of Columbia is definitely a really good example of a jurisdiction that is putting a lot of resources behind oral health care. And it's an example to the rest of the country.
Yeah.
And a shout out to Natalia Chalmers. I mean, we
Yeah.
have the best chief dental officer in CMS. So Fred, now's the time.
So can I just say one thing? And I saw the statistic too about the District of Columbia, and I was really pleased about that. But the one thing being the boots on the ground practitioner, even with how great the statistic looks, what makes everything difficult in my shoes is that a patient comes in, you diagnose them, you create a treatment plan. But in order to provide, and this is straight Medicaid, in order to provide optimum service or health care for these patients, you have to prove that you're telling the truth. There is so much red tape. You have to do everything except for offer your firstborn to be able to provide optimum health care to patients, and it shouldn't be that way. And I understand there's risks and there's concerns and lack of trust. But if your record shows that you are providing these kinds of treatments and making people better, it may take weeks in order for you to be able to be approved to provide treatment. And I think that needs to change. Now, I don't know too much about the political arena and all that legislative process, but that's why we have you. So help us, Sister Howard, please.
You better believe it. That's what we're here for. And the paperwork burdens around providers being able to become eligible for Medicaid it's not just a dental problem. It's a problem throughout the program. And so we're with you. And it's a really important piece. The other dimension of this as well, I think, is we know that most dentists don't accept Medicaid. So even if we have the benefit in place, is there real access? And there's a lot of dimensions to that. The thing that people point to right away are reimbursement levels,
That's right.
which of course really matter. But the other dimension too is it's about how diverse is our workforce. Are we training dentists who are part of the community that we want to serve? Or do they see that community as other? And this is a problem throughout healthcare. I'm the son of Latin refugees, immigrants. I'm gay, and in my life, having representation in the healthcare workforce has really changed my life. And I think within dentistry, we see that it's a very, very homogeneous workforce. And that's part of the concern too, is how do we bring much more diversity into the dental workforce?
Marco, the effect of COVID to the industry and oral health in general, both short-term and long-term, what are your concerns? Because as we heard the Congresswoman said, she hasn't gone to the dentist. There are a lot of people, it's not a cost issue for her, but there was a lot of dentists who had to shut down, and then people are not getting the care, and then that's going to lead to short and long-term effects.
Yeah. So, I mean, hers is a minority case in terms of not going back yet, right? But our latest data show roughly about 90% of pre-COVID patient volume. That's where we are today.
Okay.
Right.
Has that gone up dramatically this year?
It's gone up this year. The last few months, it's in a holding pattern.
Okay.
So we're calling it kind of potentially a steady state.
Right.
What the biggest concerns are with recovery right now are staffing shortages. Yeah. So we have crystal clear data that it is a major, major problem. We have 40% of dental practices hiring, and over 90% say it's impossible to hire, very difficult or impossible to hire staff. So that's part of what's keeping the capacity down. That's partly why we're at 90%. In terms of the patient side, there aren't any indicators of some type of long-term, I'm not going to go back to the dentist, or I'm going to go once every 2 years. I mean, we've done an incredible job as a sector, I think, to reopen up safely. You know, Cheryl's the boots on the ground, so to speak, as part of this, but to really instill confidence in the public. So long term, I don't see any big kind of implications. Short term, we do have major issues hiring hygienists and dental assistants, and that right now is problem number one.
What have you seen on the ground?
Well, the pandemic affected our private practices immensely, and to be shut down, and I remember it like it was yesterday. It was March the 18th, and we weren't allowed to reopen until June 8th. So it was 10 weeks because we were categorized as non-essential healthcare workers, which was absolutely insane. And we could only treat emergencies, but everything went on lockdown. And then with the population that I treat, even after we were allowed to reopen, they were still on lockdown for months. And so
Dr. Lee, folks may not be aware of the population that you're
Oh, I
describing.
thought I had said it earlier, but it's patients with severe mental and physical challenges. And so they are all in group home settings and they were just on lockdown. And then, there was the question about how dental offices sterilize and disinfect their offices. And we've been at the top of the game since the AIDS pandemic back in the 80s. We took particular care, but then even with this, we even went as far as having the air recirculated and disinfected. If somebody sneezed, the air would be changed and cleansed. And they said 10 seconds. Is it true? Well, I don't know, but I believed them and we put that in our practices. So it's just been really tough. And have we gotten back to where we were pre-pandemic? No, we just have not. But the types of problems that we see have increased just because they haven't been able to gain
So
access.
they're
into
worse
the
because they haven't
Yes,
seen you for a
that's
while.
right.
Right. Now that makes sense. Frederick, as far as a model, whether it's internationally or statewide, as we all know, it all comes down to money and costs. And I've talked to, when I covered healthcare, so many people were frustrated at the Congressional Budget Office because they said, well, they're not giving enough credit for preventive money. Is there data out there that you can cull and make the case to entities like CBO?
So, great question. And I spent a lot of time with CBO in my life. The joke about CBO is everybody hates them because they're never saying what folks want to hear. It doesn't matter what side of the aisle you're on. What I would say is, first of all, the data are very clear that providing preventative oral healthcare services can reduce overall healthcare spend significantly and really lead to a healthier person, a more productive member of society, all those things. That's very, very clear. In my experience, and obviously I would never speak for CBO, not on their staff, they are not particularly convinced by those sorts of arguments. And they think in very kind of green eye shade terms. We know that the Elijah Cummings Act was scored at about $240 billion. That's an earmark for if we provided every single Medicare recipient oral health care, that's what it would cost. That gives you kind of a high watermark here of the kind of money we're talking about. I think that ultimately there's a lot of interactions. Will it come in? Would a full Medicaid oral health care benefit for adults come in that high? Definitely not. But it's probably over a 10-year score, at least half of that, and that's real money. Right.
Mark, are your thoughts as the economist?
No, look, the CBO's full of wonky economists like myself and stuff, so I'm brethren with them, Fred. I get it. It's a very hard buy for research, right? Do we have RCTs and that kind of research on this? No, but I'm with you. My take too is that we've moved, even in the last 3-4 years, we've moved the research and evidence base significantly, right? And that's part of your work, part of our work, part of CareQuest's work. Moving away from the federal, I do want to say that at the state level, the feedback has been very clear that these fiscal analyses have actually gotten the bills over the finish line. It's kind of eased the fiscal hawk, so to
different
speak.
situation.
It's different stakeholder, right? But I don't want to underestimate the value of that kind of wonky work, right? It's like, we've heard from Maryland, you heard from Mary, in Virginia in May, they literally were like, okay, now we have some numbers. It's not this huge ballooning of the budget we thought it'd be, and it kind of got the bills over the finish line. So I get it. It's a bigger lift for CBO, as Fred is saying. But I think at the state level, I'm certainly proud that
I completely agree with that. Completely agree with that. That kind of research, when it works with the governors, it's exactly what we need on the state level. And remember, the investment at the state level it's of a different magnitude because they get the federal match,
right?
And it's an add-on to their existing program. So as a percentage of their total budget, it's not that high. And but it's the kind of data that policymakers, governors, state legislatures want to see to understand: is there a way for me to know in a meaningful way this is going to make a difference in the lives of my constituents? It's going to have an economic benefit to the state. That research on the state level is incredibly important, and it's important on the federal level. It's just a different dialogue, and CBO is kind of built to be hyper skeptical.
Right.
So.
Right.
We have run out of time. I do, on behalf of the Hill, I want to thank our sponsor, the CareQuest Institute for Oral Health. We'd like to thank everyone for joining us and those who joined online. If you missed any portion of today's discussion, the full event will be available on thehill.com shortly. Thank you very much. Have a great day, and please thank our great panel.